Yes, we have a bariatric endoscopy session.
Perfect.
Welcome, everybody. It's great to see you all again. We're going to go ahead and start with what I think is a really interesting session this morning. It is actually our first speaker who can go ahead and get their talk ready to go will be Allison Schulman. Allison is a good friend at the University of Michigan. She's an associate professor of medicine and surgery, and she is the director of the bariatric endoscopy program there. So if we could have Dr. Schulman's presentation, that would be great. She's talking this morning about intragastric balloons and aspiration therapy, an update.
Before I jump into the specifics about what I will cover, I wanted to quickly start by framing the obesity epidemic within the United States, since I'm the first speaker in today's session. The prevalence of obesity has been increasing in the United States. From around 2000 to 2018, the prevalence of obesity increased from 30.5% to 42.4%, and the prevalence of severe obesity increased from 4.7% to nearly 10%. The impact of obesity on morbidity, mortality, and healthcare costs is profound. Here you can see the prevalence of self-reported obesity among U.S. adults by state and territory for 2019. And it is important to note that all states and territories had more than 20% of adults with obesity. You can also see that 35 of 50 states have more than 30% of adults with obesity, with the Midwest having the highest prevalence. We know that the single most effective weight loss option is bariatric surgery. Surgery leads to significant weight loss, but also improvement in obesity-related comorbidities. However, surgery alone cannot contain this obesity epidemic. Less than 1% of eligible patients undergo surgery, and furthermore, it carries a higher risk profile. Given this high risk profile, it is important to balance risk and efficacy when we think about the spectrum of obesity management. Here you can see that standard lifestyle interventions, which are very low risk, also typically only result in about 3 to 5% total body weight loss. Surgical procedures, on the other hand, are very effective, but also much higher risk. And we think that endoscopic bariatric and metabolic therapies really fill the void between these two extremes, offering alternative treatment strategies for patients. So what are the benefits of endoscopic bariatric and metabolic therapy? There are many, so clearly it is less invasive. It may also appeal to those who do not qualify for or do not want bariatric surgery, and it could bridge a critical gap in the treatment of obesity management as it reaches patients earlier, like in those with a BMI of 30 to 35 who would not yet be considered surgical candidates. Additionally, oftentimes it is repeatable and may ultimately be used in combination. And perhaps it is a better model for chronic conditions such as weight, as even the most successful of bariatric surgical procedures can lead to weight regain. There is also increasing data on the treatment of obesity-related comorbidities, including for NAFLD and diabetes. As you can see here, there are many different devices on the market, and we will go through these in some detail. We will focus on those that are FDA approved, and these generally fall into 3 different groups: space-occupying devices, gastric remodeling procedures, and aspiration therapy. For the purposes of this talk, I will be mostly focusing on space-occupying devices, and specifically intragastric balloons, and also aspiration therapy. You will be hearing about the other techniques from other presenters. But before we get started, who will be candidates for primary endoscopic bariatric and metabolic therapy? Generally, it includes patients whose BMI is over 30 and who have not been successful at losing weight through non-surgical methods, or who do not desire surgical intervention, or who require a bridge to some other surgical procedure. Contraindications are specific to a given device, but it's exceedingly important to be aware of these if you plan to perform endoscopic bariatric therapy. We will be reviewing the specific contraindications for some of the devices that we will talk about today. And as you begin to think about all these indications and contraindications for each of these potential procedures, it is important to individualize the approach and make sure that you have a team of providers who can help in the evaluation and decision making. As you can see here at University of Michigan, we have surgeons, bariatric endoscopists, bariatricians, nutritionists, psychologists, etc., and all of whom are involved in the evaluation and follow-up of each of these patients and constantly discussing next steps. The other thing to keep in mind is that endoscopic intervention should be carefully planned out in any patient with obesity. I want to highlight a thought-provoking piece that we wrote after being asked to do a procedure on a patient with a BMI of 93. We highlight the barriers, limitations, and risks that these patients experience for what would typically be seen as routine care. So everything ranging from sedation planning to preoperative optimization to whether or not the table weight is sufficient should be considered to safely perform endoscopy in patients with obesity. So moving on to the intragastric balloons. So there are currently 4 FDA-approved intragastric balloons, and these are FDA-approved for patients with a BMI of 30 to 40, although the ASGE considers patients with a BMI of over 40 reasonable candidates for use as bridge therapy to any surgery. The fluid-filled balloons are constructed of silicone spheres that are placed and removed endoscopically and remain in the stomach for 6 months. These come in several flavors and can be single chamber, dual chamber, or adjustable, which we will discuss more shortly. The dual chamber balloon, however, is no longer commercially available. This video shows how easy the placement of some of these balloons is. So as you can see, we're advancing a balloon along a catheter guided by our upper endoscope into the lumen of the stomach. And once in the lumen of the stomach, you can begin to fill this balloon with 600 to 700 cc's of fluid. I commonly will put in a little bit of methylene blue as well, so that in case the balloon leaks or pops, the patient's urine will turn blue. And then after the balloon is adequately filled, you can just remove the catheter from the balloon and it's freely remaining in the stomach. The SPATS intragastric balloon was just FDA approved this past week, but is not yet commercially available. This is an adjustable balloon, and so the idea behind this is the fluid can be instilled to promote more weight loss or removed if side effects are significant to try to prevent early explant. So moving on to the gas-filled balloons. The Obalon system is composed of nitrogen gas and 3 thin polymer ellipses that are sequentially swallowed every 2 to 3 weeks and removed endoscopically 6 months after the first balloon is placed. So when we look at the pivotal studies that led to FDA approval, you can see that the average weight loss at 6 months was somewhere between 7 and 10%. However, we know from the hundreds of thousands of patients that have had balloons placed following this, that they tend to achieve much more weight loss in clinical practice, and sometimes as much as 13 to 15% total body weight loss. We also know that gas-filled balloons may be equally as effective, especially in patients whose BMI is over 40. And finally, it's important to always individualize therapy. So fluid-filled balloons, while they may be more likely to lead to weight loss, they also may be more likely to be removed early for intolerance. So all of these balloons are generally safe and well tolerated, but when we look at fluid-filled balloons, the most common symptoms are nausea and vomiting, especially early on following placement, and also increasing acid reflux or GERD. Early removal has been reported in up to 10% of patients, although we will hopefully see this number reduced once the adjustable SPAT system is available. Gas-filled balloons, on the other hand, tend to be a bit more tolerated, with lower rates of nausea and vomiting and a very low serious adverse event profile. So what is the mechanism of action of these balloons? This was a single-center randomized controlled study out of Mayo Rochester in which 29 subjects with obesity either underwent intragastric balloon placement with a fluid-filled balloon or matched control. Intragastric balloons were removed at 6 months, and gastric emptying was measured at baseline and at various time points throughout the follow-up period, as was percent total body weight loss. These authors found that a greater increase in gastric retention from baseline to 8 weeks was associated with a higher total body weight loss, suggesting that gastric emptying in subjects with intragastric balloons is delayed but returns to normal after intragastric balloon removal. Also, greater changes in increased gastric retention were associated with greater changes in percent total body weight loss. What about filling volume? A systematic review of studies investigating the use of the fluid-filled intragastric balloon system for obesity found that there was no association between the filling of the intragastric balloon and weight loss outcomes. Higher volumes appeared to be associated with lower migration and esophagitis rates, and thus a balloon filling volume of around 600 to 650 was recommended. A recent meta-analysis published in the American Journal of Gastro looked at the impact of intragastric balloons on obesity-related comorbidities and included 40 studies of over 5,500 participants. It became clear that intragastric balloons were not only helping with weight loss, but also helped to improve many of the obesity-related comorbidities, such as insulin resistance, NAFLD, and hypertension. A more recent study looked at the impact of intragastric balloons on NASH. This center enrolled 21 patients with early fibrosis and looked at changes in histology and elastography over time. What they found was that the majority of patients did have improvement in their fibrosis scores, in addition to having some histologic regression of fibrosis. Furthermore, percent total body weight loss did not correlate with these changes. So this study was enough to allow for a breakthrough device designation for the Airbearer balloon in the treatment of NASH. I just want to bring your attention to one additional balloon that is with the FDA, and we hope for approval in the coming months. This balloon is swallowed and passes on its own, obviating the need for any endoscopic procedure. Next, we will move on to aspiration therapy. The Aspire Assist device is approved for patients with a BMI of 35 to 55. In many ways, it is very similar to endoscopic gastrostomy or PEG tube placement. The idea behind this device is that it facilitates removal of approximately 30% of calories after a meal, and patients tend to aspirate 20 to 30 minutes after a meal 2 to 3 times a day. These are the components of the system. As I had mentioned, the A tube is similar to a PEG tube, but consists of a 15 centimeter intragastric portion with a diameter of 33 French. Unlike the standard PEG tube, there are 5 fenestrations along the inner tube to facilitate aspiration of gastric contents. The extragastric portion of the tube measures 26 French and has graduated markings along its length. The extragastric tube is connected to the skin port that sits on the external portion of the abdominal wall, as you will see on a subsequent slide. The connector disc attaches the skin port and allows the skin port to open for aspiration of gastric contents during the aspiration sessions. The connector also has a counter that keeps track of the number of times it is connected to the skin port. And so when the count reaches 115, the connector locks and is no longer able to open the skin port. So the patient will need to return to clinic, which always confirms appropriate compliance. As you can see in this photo, the tube is flush with the abdominal wall, so when not in use, you would rarely know that the patient even has the aspiration device implanted. And when the patient decides to aspirate it, that's when they connect it to the skin port so that aspiration can be initiated. Dr. Sullivan and Dr. Sway recently published a review on aspiration therapy, and I really liked the contraindication section that they detailed, so I've put this in table form, and we'll just spend a minute going over this. Contraindications to aspiration therapy include previous abdominal surgery that significantly increases medical risks of gastrostomy tube placement, esophageal strictures, pseudoobstruction, severe gastroparesis, or gastric outlet obstruction, inflammatory bowel disease, especially that which involves the stomach, history of refractory gastric ulcers, bleeding, lesions, or tumors, uncontrolled blood pressure, i.e. a blood pressure of over 160 over 100, history or evidence of serious pulmonary or cardiovascular diseases such as ACS or class 3 or 4 heart failure, coagulation disorders in which the platelets are less than 50,000 or the INR is over 1.5, anemia, meaning less than 8 hemoglobin in women or less than 10 in men, in patients who are pregnant or may be lactating, patients who are diagnosed with bulimia or binge eating disorder, as this may not be the appropriate therapy for them, patients who describe night eating syndromes, patients with chronic abdominal pain or with physical, mental, or psychological disabilities that will interfere with their compliance, and patients who are high risk for medical complications such as really poor health or severe organ dysfunction. And the mechanisms of action of aspiration therapy are many. First, food particulate must be less than 5 millimeters in size to fit through the tube. And so this really requires patients to chew for longer periods of time and commonly leads to cessation of meals with fewer calories being chewed. Gastric contents must also contain liquid to flow out of the tube, and so this allows patients to really increase their water consumption and enhances satiation earlier on. Gastrocutaneous fistula may also affect accommodation, so early satiation is reported even prior to the placement of the skin port attachment. And finally, gastric aspirates seen through drain lines commonly look much more abnormal when the foods are unhealthy, and so healthier foods have a more normal appearance when being aspirated and may be desired by the patient. The original randomized control trial that led to FDA approval enrolled 111 patients, and as you can see, primary endpoints of weight loss were clearly met. But perhaps more interesting was the high overall satisfaction ratings and willingness to recommend this device to others. And all of the patients who were told that they could keep their device for longer than just 1 year did so. And so at 4 years, we published follow-up data demonstrating ongoing improvements in weight loss and also obesity-related comorbidities, such as diabetes and liver function tests. Furthermore, a meta-analysis looking at all studies published on aspiration therapy found an improvement in hemoglobin A1C and several other obesity-related comorbidities. So in conclusion, this is a rapidly growing field with many new and evolving devices. With growth brings the potential of simplifying these interventions and broadening their adoption. Additional studies on mechanism of action are needed, as this will be imperative for personalized treatment algorithms. Combination therapies are certainly on the horizon, but all of this should really only be performed in the context of a comprehensive multidisciplinary center. Thank you very much.
Thanks, Allison. That was really wonderful, and I appreciate the rapid presentation and being on time. Since we have a minute, there is one question in the chat about a randomized trial between regular feeding tubes, PEG tubes, and the Aspire Assist device. Do you have any insight or knowledge on how that's going, or if that's been even effective or started?
I actually am not aware of that trial, so I'll be interested to hear the results once they become available.
Excellent. Well, if the attendee who mentioned that could just give us a little more information about it, I was not aware of it either. So I'd be very happy to learn more about it. So thank you very much. Great to see you today, and I hope you have a time to join us in the panel afterwards.
Yeah, definitely. Thanks so much, Steve.
All right. See you, Allison.